Order, order. Good morning. This is the Health and Social Care Select Committee, back after the bank holiday mini recess. It is Tuesday the 7th of May, and we are in the Thatcher Room in Portcullis House, and we are concluding our inquiry into men's health, a subject which select committees in the House haven't looked at for a very long time. It's been a very illuminating inquiry, short but focused. And today is an opportunity for our cross-party committee of MPs to question our guests, which I'll introduce in just a second, about the inquiry that we've heard and the themes that we've drawn out, and obviously with a view to us writing our report, which we do at the end of every inquiry. And we're very pleased to have the Minister with us. Maria Caulfield MP is the Minister for Health and Women's Health Strategy. We'll come on to that at the Department of Health. And Jason Yiannikkou, who's the Director of System Oversight and Integration at the Department. Nice to see you again. Jason, we obviously knew each other when I was the Health Minister back in the day. Thanks for coming in. I'm going to kick off with you, Minister, and ask you around, obviously, on a lot of the evidence we've heard. You would imagine we've heard from organisations like the Men and Boys Coalition, the Mankind Initiative, the UK Men's Sheds Association, the Global Action on Men's Health Unlocked, the All-Party Group. We've heard lots and lots of talk about a men's health strategy from the government. Is the government considering a specific men's health strategy, and if not, why not, and how does that then fit with your strategy and your health agenda?
Yeah, so to answer your question, we haven't got specific plans for a men's health strategy. If you compare it to the women's health strategy, which is a couple of years old now. But what we have done is set up a men's health task force to bring together experts in the field of men's health.
Is this the Task and Finish group, as it's called?
Yeah. So, and we've got groups like Men's Sheds, Andy Mann's Club, Movember, all taking part in that. And what we're really looking to do is to really kind of drive forward some of the work that's happening in men's health, but also to raise the profile of some of this work as well. So, for example, the Transform Prostate Cancer trial that's taking off, we need the help and support of those groups to get the word out to men that when they receive their invitations, how important it is to go to those. We're also appointing a men's health ambassador, which we should be able to update you fairly soon on that. We've got some interviews going ahead. So there won't be a specific strategy, but there are specific strands of work that we are working on and using the Task and Finish group to really try and pull it all together, but particularly raise awareness about that work, whether it's digital health checks, prostate cancer work, the suicide prevention work, so that men are more aware of some of the health offers that are open to them.
Okay, so I remember the Women's Health Strategy being devised and consulted on when I was in the department, and presumably that then went through its statutory consultation and all that. So reading between the lines, are you telling me that the Task and Finish group is a way of basically taking what we know? Martin Todd from the Men's Health Forum said to us that men's health issues are hiding in plain sight. So is it a way of you basically taking a lot of those issues that we know are there and just getting on with it?
I think that would be fair to say, because the Women's Health Strategy is amazing. It's the first ever strategy in England. We've got over 100,000 responses to our call for evidence. But it did, as you said, take kind of years to get to where we are, where we're actually delivering on those priority areas. We have got some low-hanging fruit in men's health that we can deal with now, particularly in the prevention work. And I think probably the three key areas around suicide prevention, because middle-aged men are a high-risk group in our suicide prevention strategy. We've got the prostate cancer and lung cancer work that we're doing that men are disproportionately, obviously with prostate cancer, affected by, but also the cardiovascular disease element as well, and some of the work that we're doing there to try and improve on that, particularly around smoking, will make a big difference to men fairly quickly, to be honest. Yeah. And so there may be room for a men's health strategy after that, but we would, I think with the resources we've got, we would prefer to crack on and get on and try and drive forward some of those changes, which we need to do, whether we have a men's health strategy or not.
If I remember rightly, were there things that the women's health strategy were needed in a more legal, properly consulted on way, because there were legislative changes that were required around women's health? Is that why that had the strategy and this doesn't need one at the moment?
Well, I think women's health issues are slightly different in that women were saying to us that when they were trying to access healthcare, it was often the culture around women's health. So women would often go, say, for endometriosis, 8 or 9 times to a GP before, getting tests done. It often takes 8 to 9 years to get a diagnosis of endometriosis. Menopause, pretty similar, we're going with various symptoms before, maybe years before actually finding out they were going through the menopause and maybe never being offered HRT. With men's health, it's slightly different. And I don't want to generalise or stereotype men, but men are often not engaging with health at all. So they don't come forward for tests when they're offered them. If they're feeling low in mood, they won't go and see their GP to talk about it. So women come forward for healthcare, but their experience of healthcare is not necessarily a positive one historically, whereas men, it's getting them engaged in healthcare in the first place. So it's a slightly different element. And so the women's health strategy is about changing really the culture of how we look at the life course of a woman, that just being pregnant, periods and menopause isn't just something that happens and get on with it. There's specific health interventions that can improve the outcomes for those. With men, we know that they've got specific health needs that they're either not coming forward for, or we're not really focusing our kind of resources into getting better outcomes for them.
Yeah, interesting. And Jason, just bring you in if I may. The Minister mentioned about the Men's Health Ambassador. Where are we specifically on that? You're one of the officials of the department that works full time on these issues. Why have we not heard of that person yet?
I'm afraid I'm going to say these processes take time, which I know is a sort of slightly depressing thing to say, but it's true, they do. And we're definitely in the thick of it and seeing people, people are going through the process.
Well, you've advertised and you've got candidates.
Yes.
And you're now, interviewing those candidates, or you're sifting? Which stage are you at? Interviewing, okay. What's the key question you ask them?
The first
are they all
question,
men?
No.
Not all men?
No. The key question we ask really is a broad one, which is how would you tackle the role? What would you do to sort of raise the profile of this agenda and advance the cause of men's health?
Okay. If you appoint a woman as the Men's Health Ambassador, how do you think that's going to go down?
Well, we have to run a sort of, as you know, an open and fair process. And
I know it's the law, but how do you think that's going to go? I'm asking you the presentation of that.
I'm reluctant to get too drawn when we're in the middle of a process, as you'll understand. We have to find the right person for the job, and we'll see how the process works out.
Thank you. Could I then just ask briefly about the National Clinical Director for Men's Health role, which obviously doesn't exist. And in April, NHS England appointed a National Clinical Director for Women's Health. I think it was the first one, wasn't it, Minister? Yeah. Why don't we have an NCD then for Men's Health at NHS England?
Well, I think probably that's something that we do need to look at for the future, but it was quite a struggle to get one for women, and that was, with a women's health strategy in place, with a women's health ambassador who's a clinician and who's very supportive of having that. So I think, I think that will probably come with time, but it's not something that we've got a definite kind of step platform for. But yes, it was a bit of a struggle to get one for women. So I think... Why
was it a struggle?
I think it's just... I think there's a reluctance to kind of pigeonhole people into women's health, men's health. And I quite understand that as well, because a lot of the issues that are important to both men and women cross all divides, and actually you should be treating people as a whole rather than are they a man, are they a woman. So I can understand there's a bit of a reluctance to try and pigeonhole it into men's health, women's health, because we should be treating people across the board. But I think there are some specific elements in both that it would be helpful to have that kind of medical specialty to try pull things together, but let's see how the women's director goes, and I think if that's successful, which I'm very confident it will be, the fact that we had a women's health ambassador and seen the difference Leslie Regan's made to try and driving forward women's health, that has made the case for why we need a men's health ambassador, but we don't want to kind of make health male, female, and so black and white as that, but I think they do bring a lot to the table.
Yeah, no, I think you've given a pretty clear steer there for them. And is the National Clinical Director for Women's Health a woman?
No.
Just getting some facts out there on the record? Good. Right, let's bring in Rachel Maskell. Thank you for those opening remarks. Excellent.
Thank you ever so much. We are expecting a major condition strategy at some point. I just want to know how much will men's health feature within that, and particularly address the specific inequalities that men face, and if you can give us some indication when that strategy is likely to emerge as well.
So I don't lead on the major condition strategy. It's Minister Stevenson that leads on that. But it's going to be looking at 5 key elements of the major conditions that have the biggest impact on mortality and morbidity. We've got things like cardiovascular disease, cancer, mental health. There'll be, I think, a maternity element there too. So there will be... all those conditions are probably some of the leading causes of death in men. And the difference really, and again, I don't want to stereotype men or pigeonhole men and women, but we know that women live longer than men, but in poorer health. But we know men have a shorter life expectancy, and there's some groups of men that have obviously shorter life expectancy than others. And these are the major conditions that dictate those outcomes more generally. So I think it is a piece of work that will make a big difference, but it will also replicate the work that NHS England's already doing in Core 20+5, which is looking again at 5 major conditions and the 20% of the population that has the poorest outcomes. And within that, there are big groups of men across the country where some of that targeted work is making a difference. So lung cancer, for example, the targeted lung health checks are making a huge difference to men. They're the screening tests for those, which are often scans, smoking advice, that sort of thing. It's not just specifically for men, but men make up a higher proportion because more men smoke than women. And we're seeing, I know there's a formal review in 2025, but we're already seeing that when the lung cancer is detected on those checks, 80% of those are being detected at stage 1 or 2, where traditionally it would be 30% if you went to your GP and had an X-ray or a CT scan. So that sort of work is already happening, and what the major condition strategy will do will build on that work so that we have a strategy going forward. And I know there was some, you may pick up on this, there's some controversy about putting mental health in the major condition strategy, but we've decided to put mental health in there because we don't want to separate people out into having a mental or a physical health issue. We know that people who've got mental illness have poorer physical health, and likewise people who've got poor physical health suffer with their mental health as well. So, bringing that all together and trying to target those who are most likely to have the poorest outcomes, I think is really important. My understanding is from my colleagues is that is likely to be published this summer, and so we can update the committee when we have some more firm dates on that.
Yeah.
Can I just add to that, because I should probably confess that I'm the co-SRO for the Major Conditions Strategy in the department as well. I think one thing to draw out, having sort of read through the transcripts of your previous sessions and some of the other evidence, is there's quite a good alignment between what you're thinking about here and what we're thinking about with regard to men's health and the major conditions strategy work. And the thing I would particularly point to, and it's come up time and again in your committee, is the importance of services and things that support healthcare, sort of meeting people where they are, meeting people in the lives that they lead. So whether that's men as men or different groups in different ways, that's going to be a fundamentally important strategic sort of need really for developed health economies, including ours, in the years to come, because of the way demography is changing. So there will be some references to men's health and issues that relate to men's health in the strategy, but I think there's a more fundamental sort of alignment between the two that's probably worth drawing out as well.
In particular, the socio-economic disadvantage, which is very prevalent. I'd like to just move on to just talking a little bit about kind of the research base in this area. And you mentioned your Task and Finish group, which has a lot of organisations with a lot of experience in delivering those frontline interventions, but obviously understanding what the psychology of what is happening behind men's health does need a level of in-depth experience. And we have very few academics who are focused on men's health in the country. What consideration have you made to create a national centre for men's health, which can be a solid base for research, development, and ensure that we get ahead of the curve with addressing these inequalities?
So, I don't think we've looked at creating a centre, but our very first kind of topic on our Task and Finish group was around what research evidence is there, what research gaps are there in men's health, and there's quite significant. We did have some academics come along and talk us through some of the work that they're doing, and there is some funding that's supporting their work. And I don't know, Jason, if you wanted to just touch on some of the research that is happening in this space.
Yes, and I think this is one of those. This encapsulates one of the dilemmas in this space, because we want there to be a sort of focus on men's health, but we also want men's health and other issues to be embedded in other forms of research as well. So I know NIHR are doing some work on mental health and men, and we can sort of draw together for you some of the other things that are going on. But I think it's a both and sort of approach that we probably need, where we're thinking about this in all aspects of what we do, rather than just sort of bringing it into a particular centre.
We know there are specific issues, and if we're able to drive those issues, then obviously start achieving significant changes in health outcomes, which is really important, which takes me on to my next question. From out of the work that we've done, we recognise that interventions need to be made very early on in life, particularly with boys, and certainly looking at issues around healthy masculinity and looking at the gender stereotypes which are so dominating in our society as well. How do we ensure that we have a strategy which is cross-departmental strategy to ensure, for instance, that education system is aligned and other departments to reinforce key messages about boys' health, which obviously will then translate into men's health?
Well, I mean, we're doing this in one way with the suicide prevention strategy, because we know that for middle-aged men that they're a third more likely to take their own life than women at that age. We are doing a lot of work. Our suicide prevention work is doing a lot of work with young boys in schools. So the fact that we're putting in, we've got over 400 mental health teams now in our schools. That will be towards 50% of schools towards the end of the year, and teaching young boys what good mental health looks like, but also coping mechanisms, but also how to ask for help, but also how to support each other, so that if you know someone who's struggling, that you're able to know what to do in terms of kind of asking people, are they okay, signposting them to help. We're not doing that quite so much on a physical health level, because and with the suicide prevention stuff, that is cross-government. So we hold regular meetings with ministers, because we want suicide prevention to be everyone's business. So we do have education in there. We do have Minister for Sport. We do have DWP, DEFRA, all those government departments are on there, so that everyone is joined up in working on that. We haven't done it for physical health, and maybe that's something that we do need to look at. But I know the Department for Education, with their curriculum programme, and again, this is why it's so important to have that ambassador. Leslie Regan has been working with DFE around teaching around young women's health, which would include both boys and girls, so that boys know about the menopause and know about periods and pregnancy and that sort of thing. We haven't got that same focus on teaching them about men's health, and maybe that's something we do need to look at. But it's Leslie Regan, who's the Women's Health Ambassador, who's kind of really working with DFE on the curriculum to make sure that women's health is embedded through the education system as well. We're doing it for mental health for young men, but not so much for physical health, so that may be a gap in the market.
I certainly would recommend that in the light of the evidence that we've taken this inquiry, which shows that the inequalities start very early in life, and therefore to ensure that we've got that joined up strategy across departments could address that. I'll hand back to the chair now.
All right, thanks Rachel. Right, Paulette.
Good morning both. I want to concentrate on the issues of cancer, which Maria, you've really focused on quite a bit at the beginning. And let me start by just giving my context, because that's how I do it. As we all know, men drink more. Perhaps I'm being naive here. They smoke more. They tend to be more overweight. You tend to, especially within the constituencies, if people are going to be homeless, it tends to be men. You then find they come into the system late. The issues relating to prostate cancer affect the African and Caribbean community I think it's 1 in 4 more than other communities, because they, in my humble opinion, they associate it with their sexuality, and they don't like talking about things, and they find it very difficult to open up. So then I look at the question I want to ask is about what are you doing, Maria, to ensure that within this strategy, or within the bigger strategy, that you can really encourage people to come to us a lot earlier, but more than that, once they come to the system to say there is something wrong and we're starting to diagnose, things like MRI scans are available, because in some parts of the country it's far more available than in other parts. How can you ensure within the strategy that when you're diagnosing cancers, that it can be done at a more early stage, so that not so much about prevention, because somebody else will raise that here, but about early intervention before we get to the stage 4 prostate cancer, straight into the bone and the issues that are there, and it becomes terminal.
Yeah, no, absolutely. And I think in our task and finish group, the people there from groups like Andy's Man's Club and Men's Sheds make that point. It's about encouraging men to come forward, but when they do come forward, to make it as easy as possible to kind of engage in healthcare. And I think the lung health check is a good example of that they've really targeted to those men most, and it's available for women as well, but for those men that are called forward, they're targeting it to those most at risk of developing lung cancer, so that they're really making it sure that they're getting to the right people, rather than the kind of worried well who will come forward whenever a test is offered. For prostate cancer, you're right, and I think there's a really good example of that. For black men, they've got double the risk of white men of developing prostate cancer, and the work that Prostate Cancer UK are doing on the Transform trial, which the government has, I think, put £16 million into, is actually proactively targeting black men. So it's going to be open for recruitment in the next few months, and it will be by invitation, so you can't just volunteer to be on the trial. And it will be doing things like MRIs to see, is there a good test that can be rolled out as a screening program for prostate cancer. But knowing that black men are much more likely to get prostate cancer, they are proactively recruiting black men. So I think they want 1 in 10 of the recruits to be black men, so that it much better reflects the real group of people who get prostate cancer. So I think being a bit more proactive in terms of targeting who's suffering from certain conditions, and then making it much more applicable to them. One of the things that we hear quite a lot, so when we were talking about our NHS health checks, which were a bit curtailed during COVID, but in the last year we've really ramped them up so that people are coming forward in much greater numbers than pre-COVID. One of the things that we've had feedback on is, for men, they don't want to just hear, come and get your blood pressure checked because it might prevent a heart attack. They just then will want to know, well, what are you going to do about that? And if they know that if you come and your blood pressure is slightly high, there's medication that can help, there's dietary advice, may not be medication for life, it might be for a short period, they're much more willing to engage, rather than just sending out a bland invitation. And that's, again, I don't want to stereotype, but that's the difference between men and women. If you send a woman out an invitation for a smear test or a mammogram, they'll go. Men want to have a bit more information and want to know what the sort of outcomes are before they will engage so well. But I think because we're doing the work on who is more likely to suffer from cardiovascular disease, who's more likely to suffer from prostate cancer or lung cancer, we're targeting those groups and being a bit more supportive to them in terms of providing that information and encouraging them to come forward. So, for example, in our health checks, because we're hearing that just being sent an appointment when you might be working, or you might have kind of nervousness about coming forward to get a health check, we're rolling out the digital health check from September, so that makes it easier for men to engage. We're also going to the workplace, because we're also recognising that men are, particularly those who are in construction, who may be self-employed, will not want to take time off work that they're not getting paid for. So there's a pilot workplace for cardiovascular disease, which has got £10 million from the Shared Outcomes Fund. So we're trying a number of initiatives to try and make it as easy as possible for men to come forward, and what we need the Men's Health Ambassador to do when they're appointed, but also the various groups within Men's Health, the various charitable organisations, is to work together to give those reassuring messages to men that it's worth coming forward, because if you've got high blood pressure, we can do something about it, which means you probably won't, or less likely to get a stroke, a heart attack, respiratory, COPD, whatever it is, and so that they feel there's a benefit for coming forward. And the messaging is very different, I'm being told from the experts, for men as opposed to women in terms of getting them to come forward.
Okay, excellent. Now, my final point, it's on the same vein. It's relating to cancers and this major condition strategy that you're talking about. Maria, you've highlighted some excellent things that you're doing. What keeps coming into my head is what keeps being said to us as a committee, that the single point of leadership, things that you're talking about, they seem to be coming from everywhere. And if I was a thumping bag, it'd be thump, thump, thump. But I can't see where the source is. So how we can make sure it's embedded within the major condition strategy, and that what you're saying doesn't get lost before it gets to where it needs to get to ensure that we can roll it out and make it part of the bigger strategy that you're talking about. How can you ensure, or what are you trying to do to ensure that happens?
Yeah, so I think my first answer, we touched on kind of the three main areas around the low-hanging fruit, so suicide prevention, work around prostate cancer, which kills around 12,000 men a year, and all the cardiovascular work. That's the low-hanging fruit. But it can easily get lost in kind of all the work that's happening across the board. The Men's Health Ambassador will no doubt help with that. And so the two things we're really looking from them is, one, to get the message out to men to engage in healthcare and to promote all the various strands of work that's happening, but two, to pull those strands of work together so it is more cohesive and that we can measure the difference it's making for outcomes for men. And
where do you finally see it sitting within that top tier of government so it doesn't get lost?
Yeah, well, I think that comes back to, the point that Steve was making at the beginning is, do we need a national clinical director? Do we need to have a men's health strategy? I think that's probably a work in progress. I think we're just keen to get on and make some changes quite quickly. But I think there probably does need to be a strategic place for that to fit in. Because things like, I think you asked around, or maybe Rachel asked around physical health and young people. You know, the HPV vaccination programme is a good example of that. It was initially set up to try and prevent cervical cancer, which it does do. Boys weren't initially included in that, they are now. And the message is, it's not just about preventing future partners of yours getting cervical cancer. It can reduce penile cancer, cancer of the anus, throat cancer. There's a benefit for boys and young men in getting that vaccination, but that's got completely lost in the messaging. And so there probably does need to be a bit of a strategic view of the men's health angle, so that young boys are feeling there's a personal benefit from me for taking part in that vaccination programme. And I think there is that is a missing link at the moment.
And I'll leave it there. I think that's a good place to leave it. Thank you. And back to the chair.
All right, thanks very much. Right, Caroline Johnson.
Thank you, Chair. I've got a few questions for me, Minister. The first one is, which individual factor do you think contributes the most to the most men dying early? Which modifiable risk factor?
I mean, you would... obviously I'm not a clinician in the same way as you are, but I would say it's the cardiovascular disease element, and then the prostate and lung cancers would be the two elements, which is why we've had for a long time now the NHS health checks to try and get people with high blood pressure, high cholesterol, smoking into the system, and we've had some success with that. And that's why also there's the real drive to get the prostate cancer trial off the ground, because there isn't a screening test for men as in the same way that there is for cervical cancer or for breast screening for women. So they would be my two elements.
Okay. So one of the questions, the government's got a great strategy at the moment on tobacco, and that bill's going through committee. I should say that I'm on that committee at the moment. The other factor that I think contributes to a lot of men's deaths is obesity. And looking at the figures, we can see that 68% of young men aged 16 to 24 are of normal weight. But that drops to 39% by 25 to 34. So there's quite, although the figures are poor across the board, there is a massive jump downwards in men of normal weight between the sort of teenagers and early 20s to the late 20s, early 30s. What can the government do, without being unduly nanny state, but what can it do to try and reduce the number of men who become obese or overweight?
So there's a number of things. So in the health check, and the health checks that are done for the over 40s by the NHS are done by local government, and they do target them to their local population. So they're not a standard set of tests across the board, but weight is one of those that they would be kind of measuring when someone comes along to get their blood pressure, cholesterol, weight, smoking history done. So they can target those who may be in the bracket that are overweight. But I think your question is about how do we prevent it in the first place. And I think the government is doing a number of things, across the board, not just for men and boys, but things, like at schools, they've now got the hours worth of sport that has to be done in schools to try and get young people more active. We've put in measures to try and we've got the sugar tax in sugar drinks. We've got the calories that are now on menus, just to try and subtly make people more aware of kind of what they're taking in. There isn't a specific programme that I'm aware of that is specifically for men in relation to weight.
I mean, one of the things to add is that the NHS is very keen on sort of making every contact count, which I'm sure you've heard of, and so trying to use whatever encounter that health professionals might have with someone as a sort of doorway into having a wider conversation about those modifiable risk factors and what they might do about it. And I think some of this comes back to some of the earlier discussion about different channels, different things working for different people and subgroups of people who might find one form of engagement helpful but another not terribly helpful. So some of this is in the marketing and in the different modes of engagement. Peer-to-peer seems to be quite helpful from some of the things we've seen. I think some of the things you've heard as well. We're often more influenced by people we know and trust, as distinct from people from outside our sort of social circle. So I think that's something that might well have some potential as well, particularly for men.
Actually leads me quite nicely into my next question, which is about the contact counts. And Minister, you said earlier that men are less likely to have that contact and that opportunity with the NHS. And looking through the figures, men are more likely to be in employment than women, and men are much more likely to be in full-time employment relative to women. To what extent do you think that contributes to a reduction in contact with health services, the fact that you need to take that time off work, perhaps have a reduction in income in order to do so, to attend those appointments? And what can the government do to ensure that health services are available to men at times they're able to access them?
So the work that we're doing, and you're absolutely right, and that's the feedback we're getting from some of the stakeholders, is that a lot of men are self-employed, for example, so taking time off work costs them money, and unless they can see a real benefit right now of doing that, telling them they may have a heart attack or stroke in 10 years, they're trying to pay their bills today, and that's their priority. So that's why we've got that cardiovascular disease health checks happening in the workplace, and my understanding is they are being slightly directed towards more male-dominated places like construction sites, because the uptake in men is lower, and the aim is for 150,000 people in their place of work to get those health checks done, so to kind of bring healthcare to them rather than the other way round. Also, things we're doing around opening up pharmacies for blood pressure. We had to think I can't remember the name of the campaign, the Million Checks or something, campaign to try and get more people to get their blood pressure checked in pharmacies quite recently, so that men in particular are not having to phone at 8 o'clock to get through to their GP, then take time off to go to an appointment. If they're out on the high street on a Saturday morning, they can go and get their blood pressure checked. So I think making it as easy and accessible is certainly something that we're hearing from the stakeholders. And if you miss that opportunity, so if you if you're not there when kind of the men are there, they will just not think, oh, I'll go back and do that later. They just won't do it. One of the areas that I'm quite keen, and there's a bit of work happening in this space, is around sport. And in the mental health space, Trevor Stephen, who's the ex-Everton player, is doing a lot around mental health work at football grounds, because that's where a lot of men go on a Saturday afternoon. And again, it's about trusting relationships. They're much more likely to kind of listen to a footballer say to them, go and get your blood pressure checked, as opposed to a minister. So I think there's some really exciting work happening in this space, but in the workplace in particular, I think we'll be looking at the outcomes of those workplace checks, and if they're successful, I think it's certainly the way forward.
Thank you, Minister. And I do think the Pharmacy First thing is great. I actually went to visit the Pharmacy First service in Sleaford Boots last week, and they did my blood pressure too while I was there. And it's a great service that does expand the availability, but I think we need to look a bit broader than just that and look at how they get access to GP
yeah, and I think like you say, the Pharmacy First is brilliant, but if you're you're motivated to go and get that done, and it's about making it as easy as possible. So even if you're nervous about going to get your blood pressure checked because you've been told, if you've got high blood pressure, you've got risk of a stroke and heart disease, we've heard from men's groups that that's actually quite a message that puts men off coming forward. They want a much more positive, don't worry if you've got high blood pressure, there's something we can do about it. And so having that in the workplace, seeing your mate getting his blood pressure checked, and then he's on antihypertensive and is doing well, is much more reassuring than saying there's a pharmacy down the road. If you've got 10 minutes, go and get your blood pressure checked. So we've just got to be as accessible as possible, I think.
That's right, and of course if you're nervous, that puts your blood pressure up, which is more difficult. I've got two further questions, if the Chair will allow me. The first one is the Secretary of State talked about intimate care and the rights to have intimate care provided by someone of the same sex, should you wish that to be the case. And I know that this has gone out to consultation. But with 11% of nurses being male, how does this apply to men?
Yeah, it's a really good question, and I think I presume, I don't want to speak on behalf of men, but I presume if you're having something like a prostate examination, that's quite an intimate procedure. So it would apply to men. So in the Constitution, it would equally apply to men. But you do make a good point in terms of the makeup of some of those clinical staffing groups, that it's often, particularly in nursing, harder to get a male nurse than a female nurse. So I guess that's something we could look at.
Yes, I think the principle that applies here and is in the consultation is really about trying to accommodate the wishes of patients as far as we can. And as you will know, the material circumstances that present themselves in some situations can make that a challenge. So there's always a sort of an element of having to adapt to those circumstances. But I think the presumption is that it would be equally applicable to all people and based on their preferences.
Thank you. And then my final question comes from an article by Catherine Carr in yesterday's Guardian, she talks about a BBC Radio 4 programme she made about the boys and how she's interviewed lots of boys, young men and their mothers about various different aspects. And she comes up with some discussion of doom scrolling, the use of pornography, unrealistic expectations, and a fear of sex and intimacy, to the point where young men say they're not initiating such contact, or that they are recording such contact, verbal consent, before it starts, or even all the way through, because they're so frightened of being accused of not having obtained consent at a later date. The Me Too programme, the consent that's been taught in schools is really good stuff to protect women. I think that's great. How do we ensure that men are not frightened in this way? How do we encourage them to have normal sexual relationships?
I think it really starts at school, and that's why the work that we're doing with DFE in terms of relationship and sex advice is so important, so that at school that their young people, boys and girls, are getting that kind of education about what is a good, healthy relationship. But your point on pornography is well made, because I know I was in the debate, I think it was one of the international men's debates where Miriam Cates raised the issue of pornography and how that is affecting relationships between young men and young women, and the expectation about what a normal relationship is. And I think the availability now online of all that sort of material and it being shared so freely is very difficult. When I was young, which is a long time ago, you had a few magazines on a top shelf which you couldn't reach. Now youngsters, it's just so available, and Miriam made the point that even if you don't allow your children access to that, they will be seeing it on someone's phone or tablet, and it is having an effect on relationships in terms of domestic abuse, in terms of even I think even in things in terms of fertility as well, because it is really changing some of the relationship expectations that men have of women, and so that is something I don't know what we do about that in terms of, other than the work that's happening with the online safety work, but how you kind of reset that balance, because there's only so much you can do in schools if people are having other input in terms of what a good healthy relationship it should be like. It's quite difficult to overcome that.
Yeah, I think it's a difficult balance, isn't it? You've got young men looking at sometimes very violent pornography and having odd expectations really of what sex might be like, but then at the same time being too frightened to engage in it in case there's an accusation made later.
Yeah, so I think it's a very, very difficult time to be a young man and young woman, because you've got so much input of information coming from multiple sources. I think schools, families have a huge role, but there's only so much that they can do when there's so much information coming elsewhere. And I think it's about all of us, speaking freely about things like pornography, and maybe, making it clear that that's not a normal, healthy relationship.
Thank you, Minister.
Thank you very much. Never thought Sleaford Boots would get an airing at the Health and Social Care Select Committee, but good for them. They'll be pleased to hear that, won't they? Thank you, Caroline. Interesting. And just picking up on Caroline's excellent article she spotted there, isn't it? And raising that with you is that, often people talk about the Andrew Tate manosphere, don't they, and all that work. But I mean, how much of a problem do you think that is? Because I mean, young boys are quite capable of distinguishing between sensible and the Andrew Tate, aren't they?
Yeah, I think they are, but I think it's about making sure that they have got that information coming to them at an early stage. And I think schools are, that's why the curriculum and the relationship and sex education is so important. So you're kind of setting at an early stage what good, healthy relationships look like. But I think there is also an element of being, not knowing what to do, and I think it's very, very difficult for young boys in particular at the moment to either, from one extreme to, pornography, this is what a relationship could look like, to, how far do you go in terms of checking in a relationship what's acceptable, what isn't. It's very, very difficult for them to navigate. And I guess, that's why we need to be ensuring that they're getting that as much access to good information about what good, healthy relationship looks like as possible.
You mentioned the health checks with all three of my colleagues just now, and that you raised it a few times, didn't you? From 40, basically, aren't they? The
yes.
NHS health checks. I mean, FYI, when I turned 40, 10 or so years ago, I never was actually called for an NHS health check for 5 years.
It's every 5 years, yeah.
And some people, Rachel's saying she's never been called for one.
Yeah, so I did challenge, because it's the local governments that do this. Some councils do it to everyone, so anyone who's over 40 will get one. Some of them do it to the targeted groups that are more likely to have poorer outcomes. So that's what I think I said that at the beginning. There's not a kind of standard approach across all local authorities.
Well, I mean, and that's fine, because I mean that's what health devolution's about, and we wrote a report, ICS's, called Autonomy versus Accountability, for that very reason, because different areas will have different health needs. But I just wonder, with the NHS health checks, fascinated to hear about going to workplaces, by the way. I think that's really interesting. It'd be really interesting if you felt the desire to write to us with some more details about that. Maybe Jason, we'd be really interested to see that. But what does the NHS health check actually do, though? When you go out into these workplaces, or when people go into the NHS health check, what would a man expect to happen at that health check, and how does it interact with the vast amounts of data that the NHS holds on each of us in terms of calling people in for that?
Yeah, so my understanding is that if you've got an existing condition, so if you've already had a stroke or a heart attack, or if you've got COPD, or you won't be called forward because you're in the system already.
You're on a pathway.
You're on a pathway already. So it is for people who are generally healthy at 40 and may not have been engaging in getting their blood pressures checked. So my understanding, in most of the health checks, you will get your blood pressure checked, your cholesterol checked, your weight checked, and your smoking history. I think they're the four main checks that you would expect to have.
Would your waist measured? Because
obviously, remember what they did at mine.
Well, as men get older into middle age, that's where weight collects, and that of course can be very dangerous on lots of different levels. So I'm just wondering, did they stick a tape measure around your waist, Jason? That's what we're getting into here. That's the level of detail that we're getting into.
I didn't know I'd be discussing this on a Tuesday morning.
From Sleaford boots to your waist.
It's been a few years since I had mine. I can't actually remember whether I was weighed or measured. I was certainly given a talking to, and my blood pressure was then managed afterwards. So I think it's basically those risk factors that they look at.
Caroline, what did you and Rachel? Go on, Caroline first. Go on, you said you've hand up.
Thank you. You said you were given a talking to.
Yes.
I'm just wondering.
It's very nice talking to, actually.
I'm sure it was, but I'm just wondering whether you have any evidence about the sort of people who turn up for these checks. Are these the slimmer, fitter, healthy people who are going to have that reinforced in their own minds, or are the people who know that they shouldn't smoke and they shouldn't be a bit fat, not going when we need them to because they don't want to be lectured or given a talking to because they know it already? And they don't realise there's something that can be done.
I think it's a mix. I mean, if we're staying on my personal experience, it was because I probably had a sense that I probably needed a bit of a talking to at that point, and was happy
in
to
general as a population.
I think there is clearly some evidence, and you've heard some of it in previous sessions, that some people who it would be really great to have come forward don't come forward, and that's exactly the motivation for trying to go into workplaces, to use digital, to find other channels and ways of engaging with people.
And I think if you look at the lung health checks, because I know a few constituents who've had those, although they're looking for lung cancer in the main, and they do, I think it's an MRI that they do to see if there's lung cancer, they do then check blood pressure, they do then check weight, smoking cessation. So they use it as every contact matters, and they get people into their GPs for those routine checks. And they are predominantly people that have poorer health outcomes, either because they've got a history of smoking or because they're in a geographical area that's got poorer health outcomes, or they've got demographic indicators that would suggest that they've got poorer health outcomes. So some of the newer programmes are much more sophisticated in who they're calling forward than perhaps the kind of rollout of a health check for all.
Yeah, Rachel, what did you think?
Yeah, just on this issue as well, I'm just wondering, is there not a missed opportunity of talking around the mental well-being and social well-being of individuals in those health checks, because we obviously know the correlation between the two?
There is, and I think some of the work that we're doing around the men's suicide prevention is looking at this and is also looking at the workplace in particular as well. And I was at a big construction site at King's Cross, the new Google HQ, where they've got mental health first aiders in the workplace, and people will often say, well, they're the big construction firms, but actually it was available to anyone. So the small subcontractors, the self-employed, plumber, whoever, could all access that. So I think the workplace is more, good employers are recognising that the workplace, you've got a captive audience there, it is a place where they can do both physical and mental health checks as well.
I love it. I just wonder whether there is we were in Singapore with another inquiry that we were doing, and there's quite a lot of nudge policy being used there, where there are rewards for involvement in certain, weight management programs, for instance. And, yes, calling people to health check through good use of data, but, don't underestimate the ability of us men to deny challenges. And therefore, what is there a nudge and a reward system that you could consider to bring certain groups of men in for these health checks?
Yeah, and I think that's with the digital health check, that is an opportunity as well, because...
what is a digital health check? Just tell me in nuts and bolts.
So it's being rolled out as we speak, so it will go live from September, but it is the abilities that you can check your weight at home, you put it in, and then it will give you advice. It might point you to the 5K Couch to 5K app, or it might point you to something else, or and you can put in your blood pressure if you've got, do your blood pressure at home, or go to the pharmacy and get it done. You can put it in and it will guide you to healthy eating. This is what you could do. So it's a much more less daunting experience. It's much more you could use nudge tactics with that as well. You could come back in 6 months, put your weight in, have you reached your goal?
I'm just going to bring in James Morris in a minute, who's just despairing of my questions here. Do you ever reach out? I was at Winchester Park Run on Saturday. I hasten to add watching. Bad knees. Anyway, I was watching, and what an opportunity that is. What a wonderful health opportunity that is each weekend. A number of people doing incredible, and the energy they find in that last 100 yards is amazing. But I just wondered, is that an opportunity, given how prevalent park run is across pretty much, I'd guess, all of our constituencies, to reach out and find people for your health checks?
Yeah, and I think that's the sort of avenue that we're going down. And again, I think I mentioned sporting events as well, where you've got a kind of captive audience. And football clubs are doing a lot of work, say at half time, putting messages on the big screens at half time, offering. They could be good venues. I think some local football clubs are doing, are hosting kind of health check areas. In my own patch, our new community diagnostic centre is based at the Amex Stadium in Brighton. So if you're invited for an X-ray or a CT, you get to go to the Amex to kind of have a little look around. So it's being innovative in that way to try and make healthcare more appealing.
Well, if you're a fan of my team, people can Google who that is. You could probably do that during the game, because it would be certainly better for your health. FYI Spurs. Right, James Morris.
Thanks. Thank you, Chair. Mary, I think you mentioned earlier about how, when it comes to maternity, we've made huge strides in terms of perinatal mental health care across the country. But yet the role of fathers, fathers' mental health, the early relationships within the family are not something which have got so much attention. So what do you think we need to do more in that area? Involvement of fathers' mental health, and the relationship at that very, very early attachment phase.
Yeah, I think it is something we haven't really looked at in terms of we are doing a huge piece of work with the Maternity Disparities Group on preconception, because we often wait for women to be pregnant and having babies before we kind of recognise that there's some work that we could be doing to have better outcomes. But that is probably solely focused on the mum rather than parents as a whole. Again, Leslie Regan is doing some work with schools on that, which would include boys and girls. I guess the biggest piece of work we're doing around that is around bereavement, so baby loss, right, where we are really trying to make sure it's mum and dad and not just mums. And the baby loss certificate that we rolled out quite recently, when we initially did it, it was going to be, mums register the birth of the baby, and we pretty quickly came to the conclusion that it had to be both parents, or the option for both parents to recognise the loss that exists for dads as well as mums. And it wasn't just about registering the baby; it was for both parents to register their loss, really. So through bereavement services, and we're rolling out bereavement suites in our maternity units, which are very family focused and not just looking at mum. We are really taking that very seriously. We're not at the other end, I would say.
But I was thinking more. I don't think it's directly in your area, but the Start to Life programme, which is being rolled out, does that give some opportunities to be focusing more on the issues in relation to fathers and whatever? I'm not quite sure whether there's anything been kind of initiated in that area.
I think there is a strand of work around perinatal mental health for fathers within that programme, more as precisely as you've described there. So I think there is a recognition of the importance of that issue as part of a wider sort of programme of work to improve bonding between parents and children in those early months and years.
And the second question I had was just around interrelationship with education in maybe in the early years, or even as a boy progresses through education. And the potential, because obviously boys, part of this discussion has been about boys and men don't necessarily interact in a conventional way with the structures which are in place, particularly in a school environment and whatever. And I'm wondering whether some years ago there was work done around peer support within the school environment. It was a joint thing between DH and Department of Education. I'm just wondering whether there's potential for investment in that peer support for young boys in school so that they can talk together without necessarily having to interact with authority figures. Is there something in there which might improve some outcomes?
Yeah, that is something that we can certainly look at, because in the older men's bracket, the peer-to-peer support of things like men's sheds and anti-man club are transforming men's health. And so, you know, if you go to one of your men's sheds and someone's been for their blood pressure check and it wasn't too bad and they survived it and they're on tablets and that's gone quite well, it really does encourage others to go for their tests, and that has, you know, been transformational in terms of men's health, and you know, I can't speak highly enough of the work that they do. And so it would make absolute sense that peer-to-peer support would be equally relevant for young men as well.
Particularly in relation to mental health conversations, because, I mean, you know, if you go back a long time to when I was at school, if you felt as though you were suffering from something like mild depression, there was no way of labelling it.
Yeah.
Because we just didn't have that conversation. These days there's a lot more mental health literacy, but there still needs to be, you know, some way of that not interacting with the conventional hierarchical structure within a school. So a young boy can say, well, I'm feeling like this, and another kid who's had a similar experience can say, well, that's normal, and then they can take the conversation on.
Because there are some apps, mental health apps, that do that peer-to-peer support for young people, and they are really popular. So, you know, even Shout, which is, you know, you can text and get support that way, so you don't have to kind of speak to someone. They are really taking off. So I think it's probably the digital aspect of peer-to-peer support that in mental health for young men that I think is quite appealing at the moment.
Thank you, Joe.
Right, okay. I'm just going to ask you about the ambassador role. What are Leslie's terms? I mean, how is she? She's not full time, is she, on that? So
no,
would it be the same that's replicated across?
I think we have
potential?
put it based on the Women's Health Ambassador's role, and I think Leslie was initially for, I think it was 2 years, but she's just had her term extended.
Is it like a couple of days a month, or what is the?
Yeah, it's about that.
Yeah.
And then the men's one would be the same.
Sorry, the men's. Yeah, the men's.
You're basing it on that contract, I presume, are you? Okay, fine, that's that. And then we're just going to touch on ICBs and accountability for men's health in their different areas. You know, what are the outputs then that we're expecting from the Task and Finish group on how you will hold account ICBs for their work on this?
One of the things, and we've only really had, I think it's a couple of meetings so far. The first one was really around kind of the research and what gaps are there in men's health. The second one was focusing on the men's health checks. And because it's local government that commissions those health checks in each of those areas, there did feel like there was a bit of a disconnect between the ICB and their relevant local authority. And so when we were drilling down into the data, there didn't seem to be like a national collection of data so that you could compare Sussex with Manchester and that sort of thing. So that is something that we've kind of identified, that we as a Task and Finish group, we want to be able to drill down so that we can better see those outcomes. And it's one of those rare health screening programs that are actually run by local councils rather than the ICB. So I think that is a piece of work that we're taking up.
Just to add to that, I'm sort of mindful of your previous work on ICSs and the Hewitt Review and so on. We do need to be a bit careful about sort of gathering together a set of metrics and then sort of adding that to a whole other panoply of things that we perceive people for. I'm sort of quite taken by the idea, perhaps influenced a bit by the last question of peer-to-peer sort of here as well. I think if we can get some ICSs to sort of take a bit of a lead around this, and you've heard from Leeds, I think, in this forum that have clearly, you know, gone ahead of some others, and I think we can find some more around the country. There might be something there about sort of following, you know, them teaching their peers rather than us, sort of, as it were, defining it all from the centre, but perhaps with some encouragement from us to sort of bring it along the way. I think that's the balance we need to strike.
That would be good if you could do that, because, you know, yes, it's not about mandating them to do it, but it's about, because, you know, they're they're under a lot of pressure, aren't they? They're under fire. They've got 1,000,001 things they've got to do, and they've got challenging budgets, and you can see how this could easily get forgotten. So, okay, that's it from us, unless any members have had anything burning that's come to them. Was there anything particular else that you wanted to add in this space, knowing how we've looked at this, and it's created a huge amount of interest out there, the fact that we're looking at men's health again after a long time.
I'll just point also just to the website as well, because one of the good things that we had from the Women's Health Strategy was we put a dedicated portal on the NHS England website, so women could go there knowing it's reliable information about a range of women's health issues. We're starting to do that with men's health. So there's things like testicular cancer, low sperm count, that men can go to, and I think we probably need to build that up so that if men, are a little bit nervous about talking to their mates or going to see the GP, they can go to the NHS website and know that there's some reliable information there as well. So I think that's something that we want to build on too.
Yeah, good. Okay. Anything else, Jason? No?
Well, I suppose I'd just add that this agenda is essentially about optimising health gain, and I think seeing it all through that lens, which I think this process has done really well, takes you a long way. And I'll go back to the point I made earlier. There's a really kind of useful alignment between looking at the things that you've looked at and the way that you've looked at them and the wider agenda for health and care for the next 20 or so years. So I think this is part of a bigger sort of shift in the way we do healthcare and health policy, and potentially is really positive.
Yeah, okay.
But can I just plug the Transform trial as well, because those invitations
really
will be going out later this year. So it's for men aged 50 to 75. They'll be invited by the GP, so it's not a kind of a volunteer scheme. For black men, it will drop down to age 45 because of their particularly high risk of screening, and to go along, it's likely, my understanding, it's going to be an MRI scan to check for prostate cancer, but we really do need thousands of men to come forward so that we can try and build a national screening programme if the evidence then supports that.
That it's not, you don't volunteer for it, you're invited to it.
Yes, so your GP will send you a letter, so we're encouraging, if you get that letter, do take part in that trial. We need as many men as possible.
Equally, it wouldn't hurt if you were having a conversation with your GP to suggest that you might be interested.
I'm not quite sure which criteria that they use, but it would definitely be worth having that conversation.
But okay, well, no, the Transform trial is very, very positive. Listen, that's it. Thank you very much for your time. Thanks to everyone who's contributed to this inquiry. Thanks to everyone who's given us written evidence. It's all published on our website. All the evidence that we've accepted and published is there on the Health and Social Care Select Committee website. You can see it all, and we will write our report in due course, which I know you always very kindly take seriously and respond to. So thank you for that. And that's it for today. Order.
Meeting has ended. The proceeding has ended. The proceeding has ended.